I'm supposed to be telling you about a short case, how a student should be attempting a short case of swelling in an orthopedic postgraduate exam. Now, uh, I I need you to understand that there are two parts to a short case. One part is when the student interacts with the case, tries to elicit what all is there, what building blocks are there to build up and pick out and make a building of a diagnosis and understand what the treatment could be. And the second part is the interaction of this student with the examiner, putting out the building blocks in front of him and getting a tick whether the building is a strong one or not. Now, this case could be an exam case, but I feel that it is also about life. As you go on in your experience, you will realize if you follow these steps of picking up the building blocks and putting them in a methodological way, getting to a diagnosis and doing a very systematic evaluation of the investigations to guide the treatment, it takes you long and also the life of the patient. So my presentation would be of a short case, and I will try to act like a student who is going to present a short case in an exam. And in between, I'll come out with some uh, answers which are more closer to correct, and the examiner expects it in that way. So in this present scenario, every student is supposed to be knowing the SMS, which is sanitization of the hand, maintaining a social distance, and using a mask. This behavior is going to be observed in each of your exam. I see that a DNB exam practical is coming in 2 days, and this behavior is going to be observed by your exam. So ask for a sanitizer, wear a nitrile glove, wear a mask. The patient's supposed to be wearing a mask, and maintain a distance when you're doing your presentation. So my patient is Sapna, a 30-year-old female, a homemaker, married with 2 children, a resident of Delhi, and has presented to me today on the 16th of August. We need to be asking all these from a patient and, if allowed in the exam, conveying the same. There is an evolution which is happening regarding the exams in the current scenario and also in the past and the future. If you look at the DNB exams, now there is no longer short case. There are cases and they are marked equally. So there is an evolution that short cases are becoming slightly long and long cases are becoming slightly short. To take it even further, due to the current scenario, the concept of virtual case scenarios, the system which various exams like the FRCS and the MRCS follow, the concept of keeping voluntary mock cases in the exam and eliciting signs on them is going to be the new reality in exams. So I can tell you that there's going to be a change. So probably we need to take even a short case with a bit more detail than we used to. Saying that, still in the exams, the time given to a short case probably would be much less than given to a short case for you to evaluate. So you need to be systematic so that you can pick up things fast. So the first thing we want to know is the demographic data, and there is a mnemonic for this so that you don't miss out anything by Nasomra, which says the name, age, sex, occupation, marital status, residential address, and date of admission. All these are important. You have been told in your previous lectures and tutorials about the importance of each. So coming to my case, I'm presenting a case with a swelling on the right wrist for past 1 year and pain in swelling for the past 2 months. Be very clear and crisp on the presenting complaint, the duration, and it has to be presented in a chronological order. You need to take back the patient to the time that when was he absolutely fine. Once you've done that, you need to extract some history of this presenting complaint from the patient. Now, the patient which I'm dealing was apparently well when she noticed a swelling on her right wrist 1 year back. The swelling appeared insidiously. It increased in size progressively over a long time of 1 year. And what was the progress like? It increased from the size of a grape to a size of the lemon, which has reached at the current examination. The swelling has become painful for the last 2 months. So this whole thing gives you a biological behavior of what you are dealing with. A 1 year duration with the 80% time it was not painful. In the last 2 months it's become painful. So for any bony swelling, the very important thing you need to tell is the site. About any symptom, that is the most important in a swelling is the swelling itself. You need to detail upon the onset, duration, and the progression, which I have already done. We don't have to close our mind to the fact that we are dealing with a bone tumor. We are building up our blocks. We need to ask the patient whether he took any treatment and what was the response. If there is a history of a remission and a relapse, you know it is something else. So don't close your mind. You need to know the onset, duration, and progress of the swelling, and if any treatment was taken and what was the response. So the pain in the wrist was of insidious onset, no history of trauma. Suddenly it started around 2 months back. It has slowly progressed to the current severity. It is not throbbing, it is not very severe, it is a dull sort of an ache. It persists all day long. It doesn't wake the patient in the night during sleep. It is definitely aggravated by wrist movement, and there is no history of significant trauma. Now, trauma and tumor in orthopedics are related in the way that every patient is going to say, yes, I had trauma. But there are two aspects. One is, are we dealing with a patient who has a fracture with an insignificant trauma, classifying it into a pathological fracture? Or we are having a patient who has a pain and a swelling, but the trauma was insignificant. So about pain, I've detailed this much about the patient, but whenever we talk about pain, we follow this mnemonic of Socrates so that we don't miss out certain things. Beyond the onset, duration, and progression, we need to know about the site, the character, the intensity, and the radiation. So the Socrates stands for site, onset, character, radiation, association, time course, exacerbating and relieving factor, and the severity. So if you see, my description almost covered everything. In addition, patient presents with gradual limitation of movement of the wrist over the last 3 months, both in the volar and the dorsal direction. There is difficulty in performing heavier activity of daily living, like lifting a bucket. There is also limitation of finger movements in the terminal range in the last 1 month, meaning there's some amount of difficulty in making a fist. And there is no numbness in the hand. So this additional history was not a part of the presenting complaint, but when we interact with the patient, we get out certain more features, which tells you about what functional disability the patient has had and what additional problems this swelling is creating. Negative history, it is always required. You need to impress upon the examiner that you know that there could be certain other conditions which could be presenting in a similar way. So those histories you need to ask and you need to convey them. There is no history of associated fever, night pains, or weight loss. No history of swelling anywhere else in the body. No family history in any other sibling or parents of swellings in the body. No history of prolonged illness, hospitalization, surgery in the past. Now, this last negative history is a constant negative history because any prolonged illness, hospitalization, or surgery could be related to the current problem. Functional disability has developed over the last 1 year, more so in the last 3 months. Patient is still able to carry out all activities of daily living. However, heavier work has been shifted to the left hand. So, as mentioned earlier, you need to have a certain bigger guides which take you towards the diagnosis. Musculoskeletal swellings could be either painless or painful. If they have been painless throughout, it's a feature of a soft tissue swelling, a soft tissue sarcoma, which tend to be painless till a pretty long time. And if you have a bony lesion, the benign tumors are supposed to be painless for a longer time. But if a pain is associated with a bony swelling from day one, it gives you a hint that you are dealing with a more aggressive or a malignant bone tumor. So that completes your history. In a short case, you might not be asked about a provisional diagnosis at this point of time because the history is very small and it's not possible most of the time to come out with a provisional diagnosis at this time. So you continue with your evaluation, the examination, which is based on the pillar of look, feel, and move, and look at the functional disability also. But while beginning, the evaluation of the patient's general health and a head-to-toe quick checkup on the general physical evaluation of the patient as has been already emphasized what all needs to be looked, considering that we might be dealing with a tumorous condition. So moving to the clinical examination, as I told you, it has three major parts: inspection, palpation, and movement. The patient has a single swelling on the radial side of distal end of right forearm, extending both volar and dorsal side of the forearm. It is a diffuse swelling ending abruptly at the wrist joint distally. However, on inspection, the proximal extent is not very clear, meaning it is merging with the normal soft tissue contour of the forearm. On inspection, the size appears to be around 6 into 5 into 4 centimeters, and the skin over the swelling appears almost normal. And what could be normal? I put 3 stars over there. Normal is, we in musculoskeletal evaluation, we always have the normal limb on the opposite side. So if the skin is looking pretty close to what is the normal limb on the other side, that is what is normal. And why we are emphasizing on this fact is because this is one of the major differentiating feature between a benign bone tumor and a malignant bone tumor. A malignant bone tumor would have a stretched out, shiny skin and will show features which suggest that there has been a very fast, rapid growth of the tumor. So have we missed few things? Here is something. Now here is something which is a mnemonic, which is based on the chapter of Das on how to evaluate a swelling, and our surgical colleagues use this very commonly. It's a recent mnemonic. MI stands for Mumbai Indians and Sena stands for the team Mumbai Indians, and they're popular for hitting sixes, so that is the 5 6s. So Mumbai Indians Sena hits 5 6s. These are the points which need to be looked into in inspection. And what are the 5 6s? Site, size, skin, surface, and shape. So these are features you can pick up on inspection. What does Mumbai Indian stand for? It stands for movement and impulse. May not be always there in a bone tumor, but remember, we are still collecting the building blocks. We are still developing our diagnosis of the swelling which we are dealing with. What is sena? C for cough. What is the exact size, the number of swellings, and any other associations, whether there is a scar, whether there is a sinus, whether the scar is a surgical one. The surgical scar itself might give you a hint at the end of the day that you are dealing with a recurrence. So inspection findings, Mumbai Indian Sena, 5/6. Let's move on to the palpation. The temperature of overlying skin is normal. There is mild tenderness present over the volar aspect of the swelling, but more or less it is non-tender. Overlying skin is normal. You can pinch the skin over the swelling all around. Surface of the swelling is smooth with variegated consistency, more so towards the volar aspect where there was tenderness. On deep palpation, there is eggshell crackling on the dorsal side where there is no tenderness and the consistency is firm. The swelling has well-defined margins distally, but slightly fuzzy margins proximally. The swelling is non-pulsatile and non-reducible. There is no distal neurovascular deficit or any pressure effects. Question asked, how do you look for temperature, back of the hand, how do you look for fluctuation? So you might need to answer these because normally we are not tuned to examination of a swelling, so please practice each one. So another query on the top, are we missing anything? Another mnemonic. So it again comes from Mumbai Indian because they have been hitting so many sixes. We are blowing whistles twice, that means fir CT 3 bar. So fir is FIR, so twice fir. F is for fluctuation and fixity to structures around. I is for impulse on cuff and indentation. R is for reducibility, relation to underlying structures. CT, 3 bar मारनी है, thrice CT. So confirm inspection findings, compressibility, consistency. T is for temperature, tenderness, and trans-illumination. Now trans-illumination, please don't close your mind. You might be dealing with a cold abscess. You might be dealing with an abscess. You might be dealing with a cyst. You might be dealing with a swelling around the back of the patient. Might be a syringomyelia. So the two mnemonics which I have given you are not necessarily in the order which you need to do the evaluation. Definitely the temperature and the tenderness is first. These are easy things to write down and confirm that you've looked into everything, because in examination of a swelling, there are quite a few points which you might miss and it could become a nagging point at the end of the day. So how do you determine that the swelling is fixed to or arising from the bone? This is a very, very common question answered, and this becomes a stumbling point. We don't have to go into a very, very complex management scenario. We need to address these small building blocks very clearly. The swelling is continuous with the bone when I palpate the edges of the swelling. Meaning, when I palpate the normal radius in this patient, and how do I do that? I actually have to palpate from proximal to distance. I need to revise my elbow evaluation, in which we used to pick up the radial head by supination pronation and gradually come down along the bone. Since there is a swelling distally, you can't go from distal to proximal. So you follow the bone, go distally, and see if you can have any difference. Can you insinuate your finger between the swelling and the bone? So if you can't, the swelling is in continuity with the bone, and when you supinate and pronate, it moves with the same bone. That is the reason that the swelling is arising from the bone. And the last part is, don't forget, although it's a bony swelling, you need to evaluate the movement, the volar and the dorsiflexion. In this patient, the volar flexion is restricted 0 to 40 degrees, and dorsiflexion is restricted to 0 to 50 degrees. Do practice using your goniometers. Only ulnar deviation is possible and is decreased as compared to the opposite side. So there is no radial deviation possible at all. This is mandatory to do because it tells you about the effect of the swelling on the adjacent joint. So we finished our history and examination, and the question comes is, what is your provisional diagnosis? So my provisional diagnosis is it's a benign neoplastic swelling of the distal end of radius in a 30-year-old female. Is there a mathematical rule to define what should be the components of a diagnosis? Yes, there is one. In orthopedics, we like to have these three things: the anatomy, the etiology, and the pathology. So the anatomy is the distal radius, the pathology is a benign neoplasm, the etiology we are not committing right now, which type of a neoplasm, because probably we need more building blocks to come to it. And it is nice to add on any complications or any other associated things which are glaring and should not be missed. Things like there is no distal neurovascular deficit and it is a right hand dominant patient. In an upper limb evaluation, if you give the dominance in your diagnosis, it takes you higher than most of the others who are presenting in case. And in a bony swelling, age of the patient has a very high significance, so it makes a part into the diagnosis. So why do you call it a benign swelling? So we just seen that why it is called a malignant swelling. So why is it called a benign swelling? You need to take a clue from each part. History. Brief history suggests that the swelling appeared insidiously, following by pain, and the swelling was progressed from the size of a grape to a lemon in the last 1 year. And the pain only came in the last 2 months. So it suggests the biological behavior of a swelling. And on inspection, the skin is not stretched or shiny. There are no dilated veins or any discoloration. There are no secondary skin changes like loss of hair, any angry looking situation, or an ulceration or fungation. This is what we mean by the skin changes you can see here. And on palpation, the local temperature is not raised, which normally would be raised in a malignant aggressive tumor. Majorly non-tender swelling. It has well-defined edges. The surface is smooth and bony hard or firm. The skin is not tethered, and it is not tethered to any surrounding soft tissue. And there is no severe pain on movement. However, when the patient does heavy work, there is some pain. So these are the supportive evidence that we are dealing with a benign lesion. So how will you manage this case? You will confirm your diagnosis. I will do radiological investigations, which are going to be radiographs and MRI. And remember, management means diagnosis plus treatment. So what will you look for in an X-ray? Before the X-ray is put in the exam, where somebody is searching, you might be asked this question. And there were the classical Annie King's 6 questions, which were there in a bony swelling. And in the latest edition of Apply, it has been detailed a bit more than 6. You want to know the age of the patient. Want to know which bone is affected and where is the bone, in which part of the bone is the lesion. What is the lesion doing to the bone? What is the bone doing in response? Is there a periosteal reaction specifically? Is there an associated soft tissue mass specifically? What is the nature of the matrix? Osteoid, chondroid, or fiber? Is the lesion solitary or multiple lesions? So these are the things I would be looking at an X-ray. So here comes the X-ray. You need to practice describing an X-ray. Now, this is an X-ray of a skeletally mature person of the distal forearm with the wrist and part of the hand of the right upper limb. It shows an expansile lytic lesion in the epiphyseal-metaphyseal area of the distal radius. It has geographical margins proximally. with an area of sclerosis. There are multiple septae in the lesion. However, the matrix is empty. There is neither calcification nor ossification. The cortex is thinned out and it is ballooned out. There are doubtful areas of cortical breach on the radial side, on the dorsal side. There is no periosteal reaction. There seems to be a soft tissue mass in the proximal area in the lateral view, pointing towards the soft tissue mass. The fat planes in the soft tissue are visible very well and they are displaced. So that almost completes X-ray description. So you could be asked straight away, what is your first diagnosis at looking at this X-ray? And if the question is like that, your answer has to be that my first diagnosis would be a giant cell tumor. Here is when other questions would start. Okay, is this a common area for a giant cell tumor? Or where all can it happen? You would say that the commonest is the distal femur and the proximal tibia, and third comes the distal radius, and the proximal humerus is the fourth. Other areas could be the spine and the sacrum, and when it occurs in the sacrum, it occurs more often in the ala. So this is a smart way of answering to the question. So when you're so smart, you would be asked that, is there any radiographic grading of such a lesion? And yes, there is a Campanacchi grading. You would say it grades it into grade 1, 2, and 3. Grade 1 is a cystic lesion. Grade 2 is an expansile lesion with a thin cortex but no break in the cortex. And grade 3 is a destructive radiolucent lesion with cortex break and soft tissue extension. Is there a relevance of this grading? Yes. It tells you about the biological behavior and it leads you towards the treatment protocols. So site has been emphasized since the beginning, and obviously the next question could be enumerate other tumors which could arise from a epiphyseal area. And epiphysis is easy because there are three: chondroblastoma, clear cell chondrosarcoma, sarcoma, and giant cell tumor. You should be ready with the other questions like the metaphyseal lesions, the diaphyseal lesions, the flat bones, the vertebral body, and the posterior elements of vertebra. Bony swelling and tumors is about a lot of names, and at times you go blank. So you need to rehearse this, and the questions could be in different types. It could be epiphysis, metaphysis, diaphysis. It could be flat bone. It could be vertebra, vertebral body, and the posterior arches. Let's move further. Do you have a differential diagnosis? Now it depends. Now in this case, I would say, looking into the history, evaluation, and the X-ray presentation, it appears pretty close to a diagnosis of a giant cell tumor, but I would always keep a differential diagnosis of an ABC, a chondromixoid fibroma, brown tumor, a non-ossifying fibroma, and a giant cell rich osteosarcoma. The examiner is trying to ask you that what could be a differential of a GCT. You are trying to tell the examiner that you know the rest. Next question is, what is GCT variants? These are the tumors. So GCT variants are lesions which have giant cells in histopathology, and clinico-radiologically they could be pretty close to a giant cell tumor. You would be asked enumerate them, and there are various ways of learning them. One of them is you go by A, B, C, D, E, F, G. A is for ABC, B is for brown tumor, C is for chondroblastoma, D is for desmoid fibroma. So that's one way. And the other way is an easier way in which you have two cysts, the ABC and the UBC. We have two cartilage lesions, the chondroblastoma and the CMF. We have two fibrous lesions, the fibrous dysplasia and the non-ossifying fibroma. We have two malignant conditions, the giant cell osteosarcoma and the malignant fibrous histiocytoma. And we have two other lesions, the brown tumor and the giant cell eruperative granuloma. If you refer to different books, you will have different add-ons in giant cell variants. So don't get surprised if the examiner asks another one or if the examiner doesn't agree with one of them, like a malignant fibrocytoma is there in some books, it is not. Hemangioma is there in some books, and it is not in others. So how will you manage? You got your X-ray. Do you want an MRI? Yes, I want an MRI. Here's your MRI. So for an MRI, as discussed before, it is important to pick up what are the sections, the coronal, the sagittal, and the axial. You need to pick up what are the sequences. Now, this is basic knowledge. So this basic knowledge is mandatory in post-graduation. Beyond that, the detailed description might not be required. Now, if I have to look at this particular pictures which have been picked up in this case, I can specifically see that there is a breach both dorsally and volarly. So it tells me about the breach and a soft tissue mass. It tells me about the extent of the tumor. So you can see here there's a coronal and a sagittal image. There is a suspicion of breach even on the dorsal side. The extent is important because that defines the planning of a surgery. So if you ask me, this much knowledge, if you can communicate in the exam, is very good. You could say that these tumors are low signal in T1 and high signal in T2. That gives you an extra mark, but not much of detail beyond that. So, Anneking staging, we've already talked, but you need to know there is a staging for benign conditions. Giant cell tumors could be pushed in the benign scenario where you put them into latent, active, and aggressive. And in my patient, I would consider this patient into aggressive because of the bone destruction, the soft tissue extent, and the principles of biopsy, we have already talked, performed by the senior surgeon, the site, the bony tract, away from the neurovascular, longitudinal incision, should not be through facial planes. Is there any histological grading in giant cell tumors? Yes. Jaffe has given a histological grading into grade 1, 2, and 3. It talks about the mononuclear cells and the giant cells. And the next question would be, what is the relevance of this grading? When it was described, it was thought that it will give you an idea about the behavior of the tumor, but now it is losing its importance because it is seen that the clinical correlation is not so great. Now we come to the treatment. So now you made a diagnosis of a giant cell tumor of the distal radius on the right side in a 30-year-old female with no distal neurovascular deficit, and radiologically it appears to be an aggressive lesion due to the breach in the cortex, and you assume that you have done the biopsy and you got a biopsy report of a giant cell tumor. So how would you treat the patient? You counsel the patient, you talk to the patient. This is a very important response in any case you're allotted. What do you want to counsel? If you have a biopsy report, no? You need to tell the patient what he is come with. Patient doesn't know anything. He needs to understand what the disease is, what the prognosis is, what the treatment options available are, what is the rehabilitation time like, how much time each treatment option is going to take. You need to emphasize regarding GCT at least that this is one tumor which is not life-threatening, but then it is bound with huge amount of recurrent rates which vary from 20 to 40%. So you can be asked about any medical therapies. Denosumab is in. It can come as a short case. You need to know about denosumab. You need to know about its indications. You need to know about its mechanism of action. And the next, of course, the surgery. You need to know about curettage versus resection. What are the indications of each? If you do a curettage, what is an extended curettage, and what are the adjuvants which are used? If you do a reconstruction, what are the options available? You need to remember there has been a talk of fibula over so many years, and ipsilateral fibula is a popular answer because it matches to the distal and the radius very well. So again, you could be asked about the types of resection And one of the types of reconstruction after resection in such a patient which has come to me could be the medialization or the translocation of the ulna and fusion of the wrist. So that completes the presentation of a short case from history, examination, investigation, biopsy, some amount of theory questions, and what way you should be answering the treatment. Thank you very much. And if you want to look at few video examples of how to do an evaluation of swellings, you can go to the YouTube on Ortho has 609, where I put in evaluation of the shoulder joint, like in a short case, like in the exam, what is expected, and also on the upper and tibia. Thank you very much.